Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1.
Extract 1. Questions 1 to 12. You hear a hospital neurologist talking to a new patient called Kathy Tanner. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Tanner. Pleased to meet you.
Hello.
Do you mind if we start off by getting some background to your condition? Just in your own words, could you talk me through the reason you're here and how it all started?
Oh, please call me Kathy.
Right.
So, until 2 years ago, my husband was in the army.
Right.
We lived off base, and I had a job which involved a lot of driving.
Mm-hmm.
Whenever I was in the car, I noticed that my neck would get pretty stiff at times.
Right.
It was hard to turn my head. To cut a long story short, when my husband left the army, we moved to a new house. My neck pain was still a problem, so I decided to visit an osteopath.
Right.
He tried to fix the problem by a neck adjustment, but actually it just made things worse.
Oh dear.
I found I was losing flexibility in my neck. I began to use a heat pad, which did help at first.
Good, but was not for long?
No. About a month or 2 on, I started to get this sort of feeling that something was pulling my head over towards my right shoulder.
Right.
It was painful and embarrassing because I couldn't keep my head straight.
Of course.
I'd managed to hide it from everyone around me until then. About this time, one of the doctors I'd seen thought physiotherapy might help and sent me to a nearby clinic.
Mm-hmm.
So I started going in regularly for treatments. And one day, the head of the clinic looked at me while the therapist was trying to position my neck and whatever. And he said, "You know what your problem is, don't you?" And I replied that I didn't. And he told me that I had spasmodic torticollis, and I had no idea what that was.
So what happened then?
So he says, "Oh, it's untreatable. You just have to learn to live with it." I went home in pain, feeling depressed and hopeless.
Yes, of course.
He was just so unsympathetic and unhelpful.
Well, I'm sorry to hear this.
Thanks. So my diagnosis of spasmodic torticollis was in June. So I began to research, what I could do. I tried chiropractic treatment until December. It cost a fortune, but did no good.
Oh dear.
The pulling and pain continued to increase. I saw a couple of neurologists, and I was put on a drug called baclofen. But it really didn't make any difference.
Yes, that wouldn't do much for your condition.
Oh, right. Anyway, the one really good thing I did at that time was to join a support group for spasmodic torticollis patients, so at least I knew I wasn't alone with the condition. But mostly, I just sat at home a lot. In order to get a bit of pain relief, I got myself an orthopaedic chair, and that did give me some support.
Right.
In November, I saw something in a magazine in the medical section. It mentioned some new treatments being done at the university hospital to treat things like spasmodic torticollis with Botox. We mentioned this to our GP, got a referral, and in December I had the first injection in my neck.
And how did the treatment go?
Well, the injections really helped the pain, you know. My head returned to almost a normal position.
Right.
It did give me a few problems, like problems swallowing, but that was okay. I thought I'd received a miracle cure. I was devastated when everything started to come back like before, and I went back to the hospital in May. At this time, the results weren't quite as good. Even though they'd upped the dosages, I ended up having 9 lots of injections, plus the, various oral medications. So I can't remember what they were.
No, it doesn't matter.
But nothing really made much difference. I just got more and more confused, and loss of memory became a problem too. Just for pain relief, they ended up giving me a pump so I could give myself morphine. Finally, I saw something in my ST support group's magazine about a relatively new type of surgery being done by a local neurologist, and that would be you. So here I am.
And we will do our best to help you. Now, just a few more questions.
Extract 2, questions 13 to 24. You hear a gastroenterologist talking to a patient called Andrew Taylor. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Mr. Taylor. Now, you've been referred to me because it's possible that you're suffering from irritable bowel syndrome or a related condition?
Yes, that's right.
Okay, could you start by giving me some background?
This has been going on for many years. After meals, I've always tended to get heartburn, but I found that pretty easy to deal with by taking antacids from the pharmacy. But a year ago, things suddenly got worse, and there were other problems I started to notice. The symptoms vary a lot, and they can be quite hard to describe exactly, but the main problem is bloating.
I see.
I need to tell you about some other things related to my stomach.
Mm-hmm.
Although this isn't something that happens every day, I've been suffering from constipation in the last month. In the past, I've had the opposite problem and would rush to the toilet several times a day. I just never know how I'm going to feel from one day to the next. It's the way the symptoms are so unpredictable that I hate. It's hard to plan my life.
Were there any other symptoms unrelated to your stomach and bowel?
Well, I have a skin condition that can flare up, and I know this could be related to irritable bowel syndrome. And the odd thing is that I often have migraines more or less at the same time as the stomach discomfort, and these can go on for days. It's strange, and I didn't at first think it was anything to do with my stomach problems.
Have you noticed anything that can intensify the symptoms in any way?
Well, I have a very demanding job as an accountant. I don't know whether this has a bearing on anything, but there's a chance I might lose my job in a reorganization of my department, so that's obviously something that's making me anxious. I don't know what's going to happen.
What's the worst effect the condition has on you?
The problem isn't just that it's nearly always on my mind unless there's some pretty big distraction, but also that it's so draining. What I mean is, I often feel that I've got no energy at all. I just want to sit around and do nothing when I get home from work, to be honest. I go to bed tired, but I'm frustrated because I have insomnia much more than I ever did before. I wouldn't say I've been suffering from depression, but a condition like this can make you feel rather down.
Right. And I understand that you've investigated the possibility that your diet's responsible for your condition. Can you tell me about this?
I was told by a nutritionist I saw that people with irritable bowel syndrome often don't eat enough fiber. In my case, I don't feel that's an issue. I've followed the nutritionist's advice about taking more fluids during the day, especially water, and accept that in the past, maybe I didn't do that enough. It's hard to say whether that's made a difference, but possibly it's caused a slight improvement. I'd read that dairy products can make things worse, so I tried cutting them out, but I wasn't convinced it made any difference. I've cut back on caffeine, though not much, actually. I also paid for extensive food allergy tests, but they didn't show anything major, so that's not an area my doctor thought was worth investigating further.
What medications have you tried?
Well, I took something called an antispasmodic, which my GP says helps to relax the muscular contractions which move food through the gut, but to be honest, I don't think it made much difference in my case.
Have you taken anything else?
Well, I've been given antidepressants, and I'm giving them a go. I wasn't sure I completely understood the reasons.
Okay, well, a drug like that targets the signals being sent to and from the nerves in the digestive system. It has a calming effect on the muscles there. Do you find that this drug was effective?
Yes, I'd say it was on the whole.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a nurse briefing her colleague about a patient. Now read the question.
Mrs. Green was admitted last night for pneumonia. She came in yesterday with a cough, fever, dizziness and chest discomfort. She's a healthy 60-year-old with a history of right knee replacement 5 years ago. She's on a regular diet and has no allergies. She's at high risk for falls due to her dizziness. We changed her IV antibiotics to oral, which she's tolerating well. Her assessment is within normal limits, except for some mild shortness of breath and wheezing. Her vital signs are stable, oxygen saturation is 98% on 1 litre, and she's been comfortable during my shift. Around 5:30, I gave her 2 paracetamol for minor pain, with good results. She has an 18 gauge in her left arm. She's got normal saline at 15 mils per hour.
Okay.
Question 26. You hear the manager of a care home for the elderly talking to the nursing staff. Now read the question.
Now, a quick word about the administration of medication. It's great to see how carefully you're all following the new guidelines, and thanks to this, error rates, which were always below average anyhow here, have dropped by 40%. The surveys we've done also throw up some interesting findings, like mistakes being more common in the morning than afternoons or evenings. We're not sure why, but there's a clear pattern. Also, we know that being disturbed for any reason while working out and preparing doses is a common reason for mistakes. So please, try and avoid distracting your colleagues while they're doing this. Finally, we must be on the lookout for drug interactions, side effects, and patient sensitivities. Fortunately, we haven't had too many problems of this nature, but the care needs of the vast majority of our residents are often quite complex.
Question 27. You hear part of a morning briefing on a hospital ward. Now read the question.
Right, so overnight admissions to the ward. Greg, could you start us off?
Sure. We have Sue Deans in bed 5. She's a 54-year-old female who was brought into the emergency department by police overnight. She has a history of poorly controlled paranoid schizophrenia. She presents with chronic persecutory and paranoid delusions and also significant thought disorder. She's to remain in high dependency unit care until the stabilisation of her symptoms. We'll be observing her every 15 minutes and monitoring the level of her distress, psychosis and any response to interventions offered.
OK. I'll review the clinical and detention status this afternoon. Now, what's the plan for discharge?
Social work interventions required for placement and community support options, and that's been booked for tomorrow. Also, an application for the appointment of legal guardian may be required.
Right. We'll consider that at tomorrow's ward round.
Question 28. You hear part of an antenatal consultation at a GP practice. Now read the question.
Mrs. Summer, how can I help today?
Well, I just wanted to check something.
Okay. So you're having a home birth?
Yeah, though everyone's on at me about going into hospital. I had my last child there, but I'm determined to be at home this time, to feel more relaxed as well as safe. But I wondered about an at-home epidural if I wanted it. Going without wouldn't put me off, though.
An epidural's out, I'm afraid, because we can't do it without an anaesthetist. Just pethidine or gas and air. But they're very effective painkillers.
Yeah, pethadine's good.
And you had a bad patch after giving birth last time.
Yeah, I got really depressed. I couldn't understand it. It was short-lived, though, and I'm better prepared now. It can't be prevented, but I have read up about coping strategies.
Question 29. You hear a trainee doctor telling his supervisor about a problem he had carrying out a procedure. Now read the question.
So how's today gone, Harry?
Well, I'm afraid I had a problem taking blood from Mrs. Harris. I've done that procedure numerous times now, so I wasn't particularly worried. What I hadn't anticipated was the difficulty finding a vein. I suspect her illness means she'll have had a number of cannulas inserted over the weeks she's been here, and that's led to collapsed veins.
Well, that can happen with long-term elderly patients, and it's distressing for them if the procedure isn't done quickly.
Oh, she endured it without a murmur.
Hmm.
I'm sure I would have made a fuss in similar circumstances.
Well, I'll supervise you the next time you do it.
Question 30. You hear a doctor talking to a teenage boy who has a painful wrist. Now read the question.
Now then, I understand you fell off your skateboard some days ago and injured your wrist. Is that right?
Yes, I slipped and put my hand out to save myself. My mum says I've sprained it.
You certainly got some swelling and bruising there. But I don't think your mum's right in this case. Does your wrist hurt?
It aches, but the pain's worse when I try to grip something.
Right. Well, I suspect you've broken what's called your scaphoid bone. It's a classic injury resulting from what you describe. I can't feel any other fractures. But you'll need an X-ray to see where the two ends of the bone are. If they're not meeting up properly, you'll need an operation to sort that out. But let's see the results first.
OK.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with a cardiologist called Dr. Jack Robson, who's an expert on Chagas disease. You now have 90 seconds to read questions 31 to 36.
Today we're talking to Dr. Jack Robson, a cardiologist and Chagas disease specialist in the USA. Dr. Robson, what is Chagas disease and why is it referred to as a neglected disease?
Chagas is caused by a parasite called Trypanosoma cruzi. Most sufferers become infected when they're bitten by an insect, commonly known as the kissing bug, which carries the parasite.
Right.
People often don't realize they've been bitten, and during the initial phase of the infection, symptoms are normally mild or absent.
Okay.
70% of those infected never develop complications. For the other 30%, the disease tends to remain silent for a long time, often 30 years, but it eventually enters a chronic phase characterized by serious cardiac, digestive system, and neurological disorders. About 7 million people worldwide are thought to have Chagas, but it attracts relatively little publicity or funding for research. This indifference is largely down to it being primarily a disease of marginalized communities in Latin America, where it's endemic. You need resources to force significant action.
Right, I see. And are there any concerns in the USA about Chagas?
Yes, the insect carrying the parasite is actually endemic to the southern U.S. states. Since 1955, however, no more than 30 people have been bitten and infected while in the USA. The alarming thing, though, is that it's become apparent that large numbers of first-generation and some second-generation immigrants from Latin America carry Chagas, around 300,000.
Right.
These people won't infect others, apart from congenitally and possibly through blood transfusion, but a significant proportion end up chronically ill.
And for the benefit of our listeners, can you describe an individual case?
Well, this year a Bolivian woman, let's call her Marisol, asked me if she could be tested for Chagas. She's a long-term U.S. resident, but she'd recently been on vacation in Bolivia, and at one point she had felt unwell. This often occurs with changes in diet and living conditions, and that's what Marisol assumed was the cause. She'd actually been planning to donate blood in Bolivia, but changed her mind at the last minute. Ironically, if she'd gone ahead, the screening would have detected Chagas.
I see.
Hearing from relatives that Chagas can be transmitted congenitally was what prompted Marisol to come to my clinic. She and her partner wanted to start a family, and she was scared that she might pass the parasite on. Tests then showed she did indeed have intermediate stage Chagas.
And what issues can arise in treating Chagas?
Well, another patient, I'll call her Jennifer, felt unwell following a vacation in a region where Chagas is endemic. Tests indicated she was Chagas positive. Jennifer was then referred to my clinic where we do further tests. Meanwhile, she looked up Chagas online and understandably was distressed by what she read. "Why me?" she once said to me. She was also fearful about taking benznidazole, the main drug used for Chagas, because it has potentially harmful side effects. For optimum impact, it should be taken in the first 2 months of the disease, but by the time the testing had been completed, 10 weeks had passed since the likely date of the bite. For information, Jennifer took benznidazole and didn't react badly to it.
And do you deal with patients in later stages of the illness?
Yes, I have a 62-year-old patient called Juan. 8 years ago, he was diagnosed with dilated cardiomyopathy, and Chagas was also detected in him. If he'd been tested for Chagas earlier in his life, his long-term prospects would have been better. A year after the diagnosis, Juan was found to have type 2 diabetes. This was dealt with relatively well, though his body did initially reject insulin. Juan took drugs for his heart, and for several years was reasonably stable, but eventually monitoring revealed severe cardiac deterioration. His experience is very much what you'd expect in someone who's had the disease for years, and it's reached the latter stages. There's no cure, and the main recommendations are rest, exercise, and appropriate diet.
I see. And what can be done to combat Chagas generally?
Plenty. Researchers are working on improved drugs to treat it and a vaccine. None currently exists, but it takes at least 10 years to supply a new drug. Another idea is to develop the existing drugs in tablets of different sizes. That could and should be done almost overnight. What's currently available is designed for adults, even though infants often have the disease. There are also some very important programs using insecticides and other methods to wipe out the bugs that transfer Chagas to humans, but initiatives like those take decades rather than years.
Well, Dr. Jack Robson, thank you very much for speaking to us today.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear an occupational therapist called Anna Matthews giving a presentation to a group of trainee doctors. You now have 90 seconds to read questions 37 to 42.
Hi, my name's Anna Matthews. I'm an occupational therapist working here in the hospital. In a moment, I'm going to present a case study to you to show you the type of work I do. But first, let's think about what we understand by occupational therapy and the part it plays in patients' recovery. In simple terms, therapists like me help patients of all ages to participate in the things they want or need to do through the therapeutic use of a range of recognised activities. For example, this could be helping patients who are recovering from illness or injury to regain skills and get back to work. Or it could be supporting older adults who are going through physical and cognitive changes. What I always have to keep in mind, however, is what the individual wants to achieve. I always say that a doctor's first question is, "What's the matter with you?" Whereas my first question is, "What matters to you?" Now, onto my case study. It involves a patient called Ted, a 60-year-old man whose motorbike was in collision with a car. Luckily, the accident happened at moderate speed, but he still suffered compound fractures in both legs, in one arm, and several broken ribs. When I first met him, after 2 weeks in hospital, he was physically and emotionally broken. After all, not only was his mobility in question, but much more importantly, so was his style. Doctors had told him that he might never be able to squeeze into his motorbike leathers again. So he'd given up. Imagine how he must have felt. One day, totally independent, and the next, suddenly unable to do things anymore. Ted showed little interest in receiving treatment. Some colleagues at the hospital took the view that if he stubbornly refused to help himself, there was little they could do. It was his right, they said. But I didn't agree. Since Ted couldn't use his legs or right arm, I made sure we concentrated on what he could do with his left hand. For example, I worked on strategies to help him dress himself and things like that. We even worked on fine motor skills, like writing with his left hand. I wanted to make sure that even if he didn't ever regain use of his right arm, I could at least get him to function by whatever other means were open to him. So, how did my therapy help? Well, I worked with Ted on his hands, putting playing cards on a table and getting him to pick one up, which he couldn't do. But he then resorted to sliding the cards off the table and picking them up that way, finding a way of compensating for what he couldn't do. He'd become upset about what he felt was his lack of progress. Relearning to do things you used to do with ease can be frustrating. But in time, I got him to see that if he didn't work with me, then he'd stay as he was for the rest of his life. That was a big motivating factor. Ted had therapy for 8 months, and he had his ups and downs. For example, the day when he finally had the plaster casts removed from his legs. He built it up in his mind into a great step towards independence. In reality, of course, it wasn't. He was still unable to stand because he'd lost a lot of strength, and the doctors were still predicting he'd remain in a wheelchair. Although I'd warned him about all this, that moment still came as a big disappointment. But strangely, when something like that happens, it can be a turning point. Like many patients, Ted became even more determined to regain mobility after that. Anyway, you'll be delighted to know that Ted's story had a happy ending. He's now back at home and back at work too. Learning to walk again took every ounce of energy he had. But patients like Ted, with that fighting spirit, go from strength to strength after discharge. That's where the support of family can be invaluable. As long as they don't inhibit the patient by warning them of potential dangers at every turn. But patients like Ted tend to take charge of their own ongoing recovery, gym membership, therapy regime, that kind of thing. Seeing that gives me a real sense of pride in the work I do and the difference it can make to people.
That is the end of Part C. You now have 2 minutes to check your answers.